ask Dr. Nagaraj, PS, to continue with the topic.
Dr. Ranjit sir, it's a privilege to speak because half of the topic has already been covered, but Ranjit sir has made my job pretty easy. Today we are going to talk about the ornament of cardiac anesthetist, which is a TE. So we call it as an ornament. It's a very precious ornament. So how far is it going to be useful for a non-cardiac anesthetist, or do you always require a cardiac anesthetist to always interpret a TE report? So let us understand by the end of this talk, probably I would convince you or no. So this is how the TE probe looks like, and it's got the tip, which is almost looking like a bronchoscope, which is flexible, and these are the two knobs, what you can see there, which can anti-flex or retroflex, and it also can move lateral flexion left to the right, and you have this multiplanar angle rotation. These two buttons, what you can see over here, these buttons are used to increase or decrease the multiplanar angle. When you increase the angle or decrease the angle, the heart actually gets interrogated in various angles from 0 to 180 degrees. That is what you see in a TE image. So this is how you insert a TE probe. So always remember adequate lubrication, and when you have any resistance, please do not insert a TE probe. We're not going to indications and contraindications, but anyways, once you insert, this is how the image looks like. And since you're looking the heart from the posterior aspect, from the esophagus, you're looking the heart, the resolution is much more better than your transthoracic echo. So that is why it scores over a transthoracic echo. Now, there are depth markers in a TE probe. Based on the various insertion depths, you have various views. So views can be upper esophageal, mid esophageal, transgastric, and deep transgastric. But do we need to know about all these? No. The answer is no. It's only around 10 to 11 views what we need to know, which are basic TE views. And first is a home screen, as I call it as. So this is a 4-chamber view. And in this 4-chamber view, this is how it looks like. As soon as you enter, you have all the 4 chambers of the heart, and the left side of the screen usually has a right-sided structure, the right atrium and the right ventricle, and the right side of the screen has a left-sided structure, that is the left atrium and the left ventricle. So this is the 4-chamber view, and then once you increase the multiplanar angle, what you can see over here, I don't know the pointer. Once you see over here that semicircular one, that indicates the angle rotation from 0 degrees to 90 degrees. Now I increase the angle, this is what I get. At around 60 to 90 degrees, I get a 2-chamber. The heart actually cuts exactly perpendicular. So it is the anterior wall and the inferior wall which gets cuts. This is called as a 2-chamber view. And then you have the long axis view, in which the LVOT and the aorta also opens up at 120 degrees. And then we have, first you don't get the long axis, you get the E figure, that is the ascending aorta. Ascending aorta is, when the aortic valve is there, you got to withdraw the probe and then you get the ascending aorta. So after withdrawing, you get this image, that is ascending aorta. Then we have the long axis view. That means to say, once the ascending aorta is in place, you increase the angle. The TE probe cuts it at 90 degrees, so it takes it into longitudinal plane. So that is the longitudinal axis of the ascending aorta. Then we have the aortic valve short axis, and you have the RV inflow-outflow view. Majorly you see the right atrium, on top, which is very closer to the probe, is the left atrium. Then we have the right atrium here. Then we have the tricuspid valve. This is a RVOT, and this is a pulmonary valve, and this is the aortic valve in the center. So this is RV inflow-outflow view. Then we have the bicaval view, which interrogates both the caves, that is the SVC onto the right side and the IVC onto the left side, SVC that side, and IVC this side, and then the interatrial septum, and then left atrium above and the right atrium below. Then we have the most important one, this is the descending aortic view. And then we have the descending aortic long axis view. And most importantly, the LV short axis view. So these are the views roughly we need to know when we are interrogating a TE. So yes, after knowing the views, what a TE can tell you, what information can it give? It gives you about the wholesome cardiac function. It tells about the left ventricle, right ventricle, might be systolic, diastolic. It tells you about the normal functioning of the valves. It also tells you whether your patient is hypovolumic. It tells you about the preload, afterload, whether your heart is struggling against a resistance, and it also tells you about the regional wall, segmental wall motion abnormality within seconds. It's very sensitive and specific for getting the segmental wall motion abnormalities. It also tells you about various shunts across and thrombus, and all these cardiomyopathies and infective endocarditis is more sensitive. TE is more sensitive. So let us understand what is a normal case, what a non-cardiac surgery actually happens is a lap cholecystectomy. This is a 46-year-old, it's a hypothetical case, slightly on the obese side, and the patient is diabetic. And a TE report actually shows an LV of around 40%. See, this 40% doesn't, the anesthetist doesn't get anxious with 40% because, as you say, the 60 is a new 40 age. In the cardiac function also it's like that. Nobody finds a 60% ejection fraction in TE. You always get a 40%. So no regional wall, anesthetist is very happy. And mild MR plus not bothered, mild TR not bothered. So subjected to anesthesia, carbon dioxide is inflated. Okay, header position, all the position is over, and the anesthetist is actually getting ready to have a TE. So now, what happens is the resident comes and calls, and then there is a hypotension. So then you give a shot of phenylephrine or ephedrine or whatever vasoconstrictor, it improves. Then again, everything is okay. Then again, after some time, again there is a hypotension. Now, what is really happening here? The hypotension is not responding this time. Then you have a concept of rescue TE. Rescue TE is when? It is, where did this slide come? I think there's one more. Okay, rescue TE is actually come. Okay, there's one more slide. What actually happens is, let me play this slide first. So what actually is happening is, this is the one which is happening. That is the TR which was initially there, the TR is increased. And then the MR which was initially was being noted, that the MR is also increased. Now you give a shot of vasoconstrictors, the MR is actually increasing because you're increasing the SVRs from this side. So this is actually missing because you're not seeing the heart. So T is actually important. Okay, I'll discuss about the rescue TE later again. So this is a point to be noted. Once you understand the physiology, it's very easy to manage. It's not that we don't know to manage, it's very easy. But the understanding the physiology or what is happening inside the heart is very important. And once you see the short axis, this is what you can see. RV is also slightly, the LV is the septum is also slightly pushed towards the left. And the LV function is pretty okay. So once you know about all these, what inotrope to choose is very easy. That's what I mean to say. So this is one part of the TE. The second part would be about hemodynamic assessment, like preload, afterload, and your regional walls. So a prototype is a liver transplant. It gives you like volume of information in a liver transplant. So most of the patients coming for liver transplant are cirrhotic cardiomyopathy. What do these guys do? They have a high cardiac output, a low SVR, and most importantly, the ventricular response to any stressors, might be a volume loading or a clamping of IVC or a reperfusion, they usually don't tolerate. So that time you actually have no clue what's happening inside the heart. So in preoperatively, it's so important to assess for the hepatopulmonary syndrome, portopulmonary syndrome. Portopulmonary syndrome is very, very dangerous. High mortality rates in portopulmonary. Intrapulmonary shunts, I'll show you how do you calculate. And the presence of PFO. So look at this image. So this is an RV inflow-outflow view as I showed you before. And this is roughly a 4-chamber view. So what's happening over here is we give an agitated saline. Just take it, agitate the saline and give it to a central line or a peripheral line and follow it up with a flush. And the bubbles actually come on the right atrium. Immediately, within 1 or 2 cycles, the bubbles come to the left atrium also. So that indicates the presence of a patent foramen ovale, the PFO. When this agitated saline comes after, say, around 4 to 8 cycles, it indicates an intrapulmonary shunt, a hepatopulmonary syndrome. So this is so important to diagnose it preoperatively. Now, there are various phases in which a TE is useful in a liver transplant. First, let us have a pre and hepatic phase in which volume assessment, because you got to co-load the patient, you have to preload the patient before they clamp the IVC for a hepatic phase. So volume assessment is important. In volume assessment, left ventricular end diastolic area, when it is less than 5.5 centimeter square per meter square, it tells that it's volume responsive. And we take SVC collapsibility in liver transplant, not the IVC collapsibility. This is how we take the SVC collapsibility in bicaval. And this is how the IVC looks. That is why we don't take, because of the contribution of the intra-abdominal pressure, the IVC collapsibility is not indicated. So this IVC, then coming to the liver transplant, I think ejection fraction parameters have been widely discussed. A newer parameter is actually GLS, which is global longitudinal strain. It talks about the strain. And when you see the color mapping or color palette, the red indicates that the contractility is good, and the blue indicates the contractility is worse, or it's akinetic or dyskinetic. Then come to the RV. I think it's already been told, this is TAPC. And this is FAC, that is fractional area change, and PA pressures based on the tricuspid regurgitation. It's been told, I don't want to repeat this. So, and this is the LV function again. When they put the clamp across the IVC, nearly 2/3 of the cardiac output is cut down to the heart. So the hypovolemia chances are higher. So you have preloaded it. Still you got to see the short axis views to understand whether it is still hypovolemic or whether it is still responsive to volume based on your volume assessment. That's a 3D image which shows the contractility during reperfusion. Once they release the cross clamp, the whole of the cardiac output increases nearly by 3-fold. And you have to look in for short axis view to understand whether this RV or LV is taking the volume or no based on the contractility or regional wall motion abnormalities. And also you see about a new MR. This is a 3D image which shows about the new MR. The red one which is coming towards you. This is seeing from the left atrium. The red one which is coming towards you is the mitral regurgitation into the LA. And you see the biventricular function. You see assess the right ventricle. This is a right ventricle, that is a TAPSE assessment, that is tricuspidal annular plane systolic excursion. And as he rightly told, you can also end up seeing this when the patient is hypovolemic. What is this? See, I put a gradient across the aortic valve. You get a gradient roughly around 39 to 40, which is very, very significant. It tells that there is a gradient across the LVOT, which is SAM, systolic anterior motion. That's why it's very lethal to understand this. You see the heart, probably it's hypovolemic, and you have started giving some vasopressors, which will again increase the SAM. And last but not the least, always the anastomotic leak also can be seen based on the IVC. So you can see a laminar flow across the IVC. And worse come worse, you can see this also. Suddenly you have a perioperative MI, and the upper leaflet of mitral valve is the anterior one, the below one is the posterior mitral leaflet, and you can see a prolapse. The mitral infarction has caused a chordae to rupture, and you can also see this. That's also pretty common. So this is about liver transplant. What did you see preoperatively? You know, what did you assess? Intraoperatively, all phases you assessed, including the anastomosis in the reperfusion phase. Now let us see a carcinoma case. Carcinoma case, so we had this right radical nephrectomy patient with an IVC thrombus. This is very important. The surgeon is going to eat your brain telling that, where do I apply the clamp? Do I have a place in the IVC to apply the clamp? If you see this, this is the bicaval view. There is no thrombus inside the right atrium. When I interrogated into the IVC, if you see that image, you can see the IVC thrombus there. Can you make out this thrombus coming and going? So I have the clamp can be applied over here. Here the clamp can be applied. So you interrogate based on the 4-chamber view, see the IVC, where the thrombus is sitting, whether the thrombus is also present in the pulmonary artery also should be visualized. And then you see for the hypovolemia, once the IVC is clamped, as the same way, the heart is going to cut off all the cardiac output, so you got to adequately fill the left ventricle, see the hypovolemic. This is the renal cell carcinoma, which is the IVC thrombus, which is extracted. So this is pre-thrombus, that is post-thrombus. So there was a small peck. So very important, it plays a major role in assessing tumor thrombus extension, hemodynamic monitoring of tumor embolization into the heart also can be made out. And you can guide the surgeon for resection. How beautiful to guide the surgeon, you know. It's a nice feeling. Next, when we come to this cardiac pathology interrogation, this is a 28-year-old female who had a past history of some knee injury or knee dislocation. Then she presented with a motor accident now. Now they are posted for left clavicular RF. So the anesthesia, what you plan is your interscalene plus your GA. And initially her BP was around good BP. Now it is heart rate has come up to 145. During prepping itself, they lift the legs and they start prepping. During that time, they had a hypotension. The heart rate increased to 145 to 105. BP dropped to 80, which was around 149 oxygen sats, dropped to 71. And ETCO2 decreased to 12 to 39. You know, your eyes should open up now when the ETCO2 drops. So what you're actually doing, you started manually ventilating, whether both the lungs are ventilating or no, is there a mucus plug, all these respiratory factors you rule out, but still it fails to improve. Now you start giving vasopressors, adrenaline, 200 mics, again it's now you put a CVP, you put an arterial line, and you activate the protocol of rescue TE. Now this is what when you put a rescue TE, this is what you see. What you see here? What you see here is basically, if you carefully look into here, there is a dilated RV. Second, there is a severe RV dysfunction, but which is sparing the RV apex, which is very, very significant or pathognomonic feature of a McConnell sign, which is pulmonary embolism. Now I look into the short axis. This is the RV. Can you see hardly any movement of the LV? What the animated video, what sir has showed about the RV septum, septum pushing towards the LV, and LV is absolutely collapsed. And the RV is taking majority. And can you see the clot there in the pulmonary artery? This is the clot. Can you see the clot here? This is a clot which is in the right pulmonary artery. Now this patient, do you want to do the surgery? It's absolutely a no. So you don't do the surgery. Yes, case was deferred, taken into cath lab. They did a tissue plasminogen activator. They removed the clot. This is a case report which was published on the same background. And then later, they actually did the surgery after a few. So T is pretty fast. The sensitivity and specificity are pretty high, 80 to 97%. And however, the preferred confirmatory diagnoses are like spiral CT and all these, but real-time continuous monitoring, T scores above. Okay, similar bone cement, amniotic fluid, venous air embolism, most of them are usually presenting like this. Okay, so major vascular surgery, back pain suddenly enters the ER, and then what do? They give a pantoprazole, they give a buscopan, they give a painkiller, and then they tell that everything is fine. But what is actually happening? Then again, yeah, I will. Okay, then what's going to happen? The patient is going to have a slow pulse, steady pulse, then he loses the pulse, then actually a rescue TE comes, and then you put in the probe, and this is what you see. What do you see this? You see the aorta, the descending aorta. What do you see? You see a aortic dissection, which is a dire emergency, and you lose 1 hour. You're increasing the mortality by 3%, mind you. 3% mortality, not morbidity. So that is why you don't have time for shifting the patient into the CT room. You diagnose the aortic dissection. Most important, you have to diagnose the entry point, because the surgeon has to close the entry point. So this is the entry point, how we diagnosed the aortic dissection. And if you see the white one, that is a guide where we put the cannula in. The surgeon is going to ask whether the cannula is in the right place or no, in the true lumen or the false lumen. The upper one is the false and the lower one is the true lumen. So also you can end up seeing this, which is even more scary. This is like aortic root having dissected. Just 10 to 20 seconds, I'm concluding it. So this is aortic dissection, that's in the long axis. So this is an intrarenal aortic dissection, what we did. It's a ruptured one. Can you see the dye which has come out? The dye which has come out, that's an intrarenal aortic dissection. And I want to tell you about this case report in which the cross clamp was released after the anastomosis are intrarenal, and the patient ended up having an aortic dissection, retrograde aortic dissection. When they had a TE probe in situ, so they had a retrograde aortic dissection. This was probably in JCVA, a recent JCVA which was published. So a therapeutic impact of TE has also been stressed upon and emphasized. Okay, so take home, TE, you really want to put? For me, yes, because it's an ornament for me. So stents are, you can monitor the wholesome cardiac functions, systolic, diastolic, everything. Very important, it's a real-time continuous monitor. You need not interrupt the surgeon, you need not interrupt the surgery. And then limitations are, it needs some bit of training. And second thing is it needs intubation. Yes, of course it needs intubation, though we have done an awake one. It needs intubation. And TE is indicated in high-risk patients who are suspected cardiac patients or known cardiac patients who have a risk of cardiac complications or in major vascular surgeries or neurosurgeries. Critically with MODS, TE is definitely indicated in organ transplant, liver transplant, and renal cell carcinoma. And rescue TE protocol, unexplained hemodynamic stability with optimal medical management, you got to use rescue TE. Please go in for first rescue TE, you'll understand main thing. Okay, this is a rescue TE protocol, normal, decrease that you find whether the LV is empty or good. You see the RV area, whether it's increased or no, then you can diagnose whether it's an embolism, tamponade or hypovolemia. Thank you for the time, thank you for your patient hearing. It's time for TE or time for... Thanks. Thank you so much.